So, imagine you are standing in an operating room.
Okay, I'm there.
The bright surgical lights are just beating down on your neck,
Hmm.
right? And you have just spent, I don't know, the last 45 minutes painstakingly suturing a torn meniscus.
Yeah, which is no small task.
Exactly. And your technique was absolutely flawless. I mean, every single knot is perfectly tied. The tissue is precisely approximated. But in the back of your mind, you know the clinical data.
You know the numbers.
Right. You know that despite your perfect mechanical repair, because it is an isolated repair, meaning that is literally the only thing you are doing to this knee today, that meniscus only has a 67% chance of actually healing.
Yeah, that's a tough reality.
It really is. I mean, 1 in 3 of those perfect repairs is just going to fail. But if you were operating on that exact same patient with that exact same meniscal tear, and you decided to simultaneously perform an anterior cruciate ligament reconstruction and ACL reconstruction,
Yeah.
the healing rate for your meniscal repair miraculously skyrockets.
It's a massive jump.
It jumps from 67%, all the way up to 92%, which is... I mean, that is just a staggering biological paradox. It's been turning over in my head ever since our last session.
It is a profound jump, isn't it? I mean, 92% versus 67%. It's one of those clinical statistics that feels like it just breaks the fundamental rules of tissue healing.
Right. It doesn't seem to make any sense.
It makes absolutely no sense until you understand what is actually happening at a microscopic biological level while you are in that operating room. So if you are sitting across from an examiner and they ask you to explain this paradox to them, what is your theory? How does adding a second massive trauma to the knee somehow heal the first one?
Okay, so I have been thinking about the actual physical steps of the surgery, and I think it comes down to the bone tunnels. Because when you reconstruct an ACL, you aren't just working delicately in the soft tissue, right? You are taking a heavy motorized drill, and you are aggressively boring wide tunnels straight through the hard cortical bone of the tibia and the femur so you can pass the new graft.
Right, it's very traumatic.
Exactly. And by drilling those massive holes deep into the cancellous bone, you are essentially unlocking the vault. You're creating this internal geyser of bone marrow, whole blood, circulating stem cells, and potent growth factors. And you are venting all of that highly reactive biological material straight into a joint space that is already filling up with a fresh post-operative hemarthrosis.
Okay, let's pause right there and break down that terminology for you listening, because you just hit the absolute biological nail on the head. A haemothrosis. Translate that for us.
Right. So just breaking down the Greek there, hema meaning blood and arthrosis meaning joint. So it literally just means a joint cavity that has rapidly filled up with whole blood following a trauma or surgery.
Exactly. And, normally we don't want a joint filled with blood.
No, usually that's a bad sign.
Right. But in this specific case, it acts like a biological delivery system. Your theory is exactly right. By aggressively drilling those tunnels for the ACL, the surgeon accidentally does what we spend the entire rest of this clinical module trying to do deliberately.
Which is what?
You dump high-grade biological fertilizer onto the avascular meniscal repair site.
Oh, wow. So we're essentially weaponizing the trauma of the heavy orthopedic drill to heal the cartilage. We are flooding a barren wasteland with the nutrients it desperately needs to survive.
Precisely. Which really establishes the fundamental, inescapable theme for this entire deep dive we are taking you on today. Whether you are prepping for your final fellowship exams or you are just trying to deeply understand the vulnerabilities of human anatomy, everything we're unpacking right now revolves around one single physiological currency.
Blood supply.
Blood supply. Who has it, who doesn't, and the increasingly desperate, destructive things we have to do to the tissues that don't.
Okay, so we've established that the meniscus is starving for blood, which makes healing a total nightmare. Let's get into the actual geography of that starvation. Hit me with a clinical scenario. I've been reviewing the anatomical zones all week, and I want to see if I can map this out the way an examiner would demand.
I like the confidence.
Yeah.
Let's start with a classic presentation to really anchor this for you and everyone listening. Imagine a 25-year-old patient who sustains a severe twisting injury and presents with a meniscal tear.
Okay, pretty standard.
Right. So we are looking at the meniscus arthroscopically, based purely on intrinsic biology. Which specific zone of that meniscus offers the absolute greatest healing potential if we decide to pass a suture through it.
Well, based on what we literally just discussed about blood being the ultimate currency, it has to be the most peripheral edge. That would be the red zone.
Red zone, exactly. Now, examiners absolutely love testing these geographical boundaries because they dictate your entire surgical decision-making tree.
Because it changes what you can actually repair.
Right, so define all three zones for us, moving from the outside in.
All right, picturing the knee joint in cross-section, and we're moving from the outer capsule inward toward the empty center of the joint. The red zone is the peripheral third. The red-white zone is the middle third. And the white zone is the central third, the part that tapers down to a thin edge.
Peripheral third, middle third, central third. Spot on. Let's expand heavily on the deep anatomy behind this, though, because it dictates the entire natural history of meniscal pathology.
Let's do it.
So, the peripheral third, that red zone, receives a rich, robust blood supply directly from the parameniscal capillary plexus.
Okay, so it has its own dedicated plumbing.
Exactly. These are microscopic vessels branching off the larger genicular arteries that physically wrap around the outside of the knee. Because it has a direct arterial blood supply, it can mount a true inflammatory cascade. It can deliver fibroblasts, macrophages, and platelets.
Which means it has the greatest healing potential.
Precisely. Now, contrast that with the central third, the white zone.
Right. The white zone is completely avascular. Like, there are 0 blood vessels, which I have to say always confused me when I first learned it.
Oh, so?
Well, if it has no blood, how are the cells in that zone not just immediately dying of necrosis?
It is a brilliant question, and it actually comes down to physics rather than traditional biology. The white zone survives solely by the mechanical diffusion of nutrients from the surrounding synovial fluid.
Okay, so it just soaks it up.
But it doesn't just happen passively. It requires cyclic loading. Think of the meniscus like a dense, wet sponge.
Okay, I'm picturing a sponge.
When you take a step, your body weight compresses the sponge, squeezing the waste products out into the joint fluid. When you lift your leg, the pressure releases, the sponge expands, and it physically sucks in fresh, nutrient-rich synovial fluid.
Wait, so simply by walking, you are mechanically pumping nutrients into the avascular tissue?
Exactly.
Which means a highly sedentary patient is literally starving their central meniscus of nutrition compared to an active runner.
That is exactly what it means. And because it relies entirely on this slow mechanical diffusion rather than a fast vascular highway, it has effectively 0 intrinsic healing capacity. If you tear the white zone, it is never going to heal. Period.
Period. Good to know. And just so we have our historical eponyms absolutely dialed in for the oral boards who map this out, I know they love asking for the history.
Yes, they do.
No.
That foundational classification system comes directly from Arnoczky and Warren, published in 1982.
Arnoczky and Warren, 1982.
That is an eponym heavily worth dropping in an oral Viva examination if you want to demonstrate a profound depth of knowledge. Before their work, surgeons were largely operating in the dark regarding meniscal healing potential.
Now let's talk about the geometry of the tear itself. Out of all the possible ways a meniscus can rip under massive rotational force, which specific tear pattern is actually the most amenable to surgical repair?
Well, the standard multiple choice options you will see are radial, flap, degenerative, longitudinal, and horizontal. What is your choice? And more importantly, why?
I would say a longitudinal tear is the most amenable. But I'll admit, my reasoning is mostly just rote memorization from the textbook. It's the one that runs the long way along the curve.
You have the right answer, but rote memorization will collapse under pressure. Let's build the mechanical understanding so you don't forget it.
Yes, please.
Longitudinal tears are the most amenable to repair, and the reason for this is beautifully architectural. If we were to place a slice of normal meniscus under an electron microscope, you would see that the dominant heavy type 1 collagen fibers are arranged circumferentially.
Meaning they trace the curve.
Right. Meaning they trace the outer C shape of the meniscus from the front of the knee all the way to the back.
Why are they laid out in a C shape, though?
They are laid down this way specifically to resist what engineers call hoop stress.
Hoop stress. Like a barrel.
Think of a classic wooden wine barrel. The wooden staves go up and down, but to keep the barrel from exploding outward when it is filled with heavy liquid, it has thick iron hoops wrapped around its circumference.
Right.
In the knee, when the perfectly round condyle of the femur pushes down on the flat plateau of the tibia with hundreds of pounds of force, the meniscus is caught in the middle. You want to squish outward and escape the joint. Those circumferential collagen fibers act exactly like the iron hoops on the wooden barrel, holding everything tightly together under load.
Okay, I am picturing the barrel. That makes total sense. So how does that relate to the longitudinal tear?
A longitudinal tear runs perfectly parallel to those circumferential iron hoops. It splits the meniscus between the thick fiber bundles rather than cutting across them.
Ah. So it doesn't sever the bands.
Exactly. So when a surgeon passes a suture needle through a longitudinal tear and ties a knot to bring the edges together, those heavy load-bearing fiber bundles are still physically continuous from front to back. The structural integrity of the hoop is entirely preserved.
Which brings us to the opposite, catastrophic scenario. What happens mechanically to the barrel if the patient sustains a radial tear?
A radial tear is a biomechanical disaster. A radial tear starts at the inner edge and cuts perpendicularly right across those thick circumferential collagen fibers, heading outward toward the capsule.
So it's basically cutting the hoops.
It is like taking a hacksaw and cutting straight through the iron hoops of the barrel. The hoop stress mechanism is instantly completely destroyed.
So even if the meniscus is still sitting there in the joint, it's not actually doing its job anymore.
Precisely. That is exactly why deep radial tears that extend all the way through the peripheral capsule are functionally equivalent to a total meniscectomy.
Wow.
You might look in with the arthroscope and see meniscal tissue physically sitting in the joint, but mechanically it is completely useless. It cannot contain the outgoing forces. The barrel bursts, the femur grinds directly into the tibia, and early arthritis is practically guaranteed.
Let me do a quick say it back here. Okay, let me consolidate this architecture for you, the listener, because you have to be able to visualize this in 3 dimensions. The red zone is the peripheral third, and because of its rich blood supply from the perimeniscal capillary plexus, it is the only zone that heals reliably.
Correct.
And then a longitudinal tear is highly repairable because it runs safely with the circumferential. Type 1 collagen fibers, preserving the structural integrity of the barrel. A radial tear cuts across the fibers, snapping the iron bands and completely killing the hoop stress mechanism.
Perfectly stated. With the fibers, you repair. Across the fibers, the hoop stress is gone.
And what about the physical location of the tear on the tibial plateau? Does proximity to the absolute edge matter beyond just the broad thirds of the zones?
It absolutely does. And here are 2 more crucial, highly tested details from our source material that candidates often blur together. Tears that are located strictly within 3 millimeters of the meniscosynovial junction, have a significantly measurably greater healing potential than those even slightly further in.
3 millimeters. Why such a precise cutoff?
Because the capillary bed is a gradient. The closer you get to the dense synovial capsule, the richer the blood vessels become. It drops off a cliff after 3 millimeters.
That is razor thin.
It is. Furthermore, there is a very helpful anatomical note that explains the physical vulnerability of the tissue in the first place. Both the medial and the lateral menisci are vastly thinner along their inner central margins in the white zone, and much, much thicker peripherally in the red zone.
So they're fundamentally wedge-shaped in cross-section, which is brilliant evolutionary engineering, right? Because that wedge shape is exactly what allows them to act as a contoured shock absorber. It physically adapts the perfectly round bowling ball shape of the femoral condyle to sit securely on the relatively flat tabletop of the tibial plateau.
Brilliant engineering for static weight distribution, yes. But that exact same wedge geometry is what makes them fail dynamically.
How so?
When the wedge is compressed too forcefully, or rotational torque is applied while the joint is heavily loaded, the wedge shape catches the force unevenly and ends up splitting.
Okay, let's lock this down with the one-liner.
Synthesizing this foundational segment into your core takeaway. The red peripheral third receives vital blood from the perimeniscal capillary plexus, while the white central third is entirely avascular, and you repair longitudinal tears because they run safely parallel with the collagen fibers, preserving hoop stress rather than devastatingly cutting across them like a radial tear.
Perfect. Moving from the biology of the tissue to the actual tools in our hands, let's talk about surgical technique. And looking at the source material provided for this module, I think we have a serious, dangerous errata we need to address head-on before a listener fails a question because of it.
We do, and these are the specific moments that can absolutely sink a candidate if they just blindly memorize a review textbook without understanding the clinical reality of the operating room.
Let's look at the specific question. What is the main advantage of an all-inside meniscal repair technique over the traditional inside-out repair technique?
Right. And for context, an all-inside technique uses those modern, expensive trigger-deployed devices.
The fancy ones.
Exactly. Whereas an inside-out technique involves manually driving long needles from inside the knee out through the skin.
Old school. So the options provided in the source are improved biomechanical strength, better visualization of the posterior horn, ease of use, decreased operative time and no incision, fewer implant complications, and better healing rates. Now, if I am reading the answer key in the source text, it confidently states the correct answer is fewer implant complications.
Right.
And honestly, because all inside devices are modern high-tech marvels, that sounds incredibly plausible.
It sounds plausible, but the answer key is entirely, demonstrably wrong. And what's worse, the source's own explanatory text in the following paragraph actually contradicts its own answer key.
Oh, wow.
The text states clearly that the main advantages of an all-inside repair are ease of use, less operative time, and the lack of an accessory incision. And then in the very next sentence, it explicitly warns that there are still significant complications with all-inside implants.
Like what?
Specifically listing implant breakage, implant migration, and severe chondral scuffing, meaning the hard plastic anchor scrapes away the pristine cartilage.
So it is logically impossible for fewer implant complications to be the main advantage, especially when the old-school inside-out technique barely uses bulky intra-articular implants at all. It mostly just relies on simple, soft suture thread.
Exactly. You cannot claim fewer implant complications when you are comparing a bulky plastic anchor to a piece of string.
So if you are sitting your board exam next week and this exact question appears on the screen, you have to ignore the source's flawed answer key and mark it as the third option.
Absolutely. You mark it confidently as ease of use, decreased operative time, and no accessory incision. That is the empirical fact.
Good to clear that up.
Now let's flesh out the rest of the biomechanical comparison between these two techniques, because understanding the trade-offs is vastly more useful to your career than just surviving one multiple-choice question. Let's talk about strength.
I assume the modern, expensive all-inside devices are vastly stronger.
Actually, no. The inside-out repair technique, specifically utilizing vertical mattress sutures, remains the undisputed biomechanical gold standard on the laboratory bench.
Wait, really? Why is the old-school manual needle stronger than the high-tech anchor?
Because of the architecture we just discussed. A vertical mattress suture drops down from above and captures those thick, circumferential, type 1 collagen fibers exactly perpendicular to the tear.
Oh, so it loops over them.
Yes, it wraps around them like a dense lasso and pulls them tightly together, compressing the tear edge to edge. It is incredibly strong against pull-out forces.
But the all-inside devices are different.
However, modern all-inside repair devices, which deploy tiny anchors on the far side of the capsule and use pre-tied sliding knots to cinch the tissue, have evolved drastically.
So the inside-out lasso is stronger in a laboratory stress test, but does that actually matter for the patient walking around in the real world?
That is the crucial clinical distinction. While the inside-out vertical mattress is measurably stronger in benchtop load-to-failure testing using cadaver knees, the long-term clinical outcomes at 5 and 10 years show that all inside repairs are statistically equivalent in the living patient.
Okay, so inside-out is stronger on the bench, equivalent in the clinic. But all inside is dramatically faster and crucially avoids having to make a large, painful accessory incision on the side of the knee.
Exactly.
Which neatly brings me to exactly why a surgeon would be so desperate to avoid making that accessory incision. Because when you cut blindly down the side of a knee to retrieve a sharp suture needle popping through the capsule, you are walking through an absolute minefield of nerves.
You are, which sets up the next critical anatomical question. And examiners love this because it tests three-dimensional anatomy.
Okay, ready.
During a medial meniscal repair, utilizing an inside-out technique where long needles are driven from the inside of the knee out through the posteromedial capsule, which specific nerve is at greatest risk of iatrogenic injury?
That would be the saphenous nerve.
The saphenous nerve. And to be painstakingly precise for the examiner, it is specifically the infrapatellar branch of the saphenous nerve.
The infrapatellar branch.
Yes. This nerve is highly vulnerable when you are blindly passing sharp suture needles through the posteromedial capsule, or when you are aggressively dissecting down through the skin layers to make your posteromedial retrieving incision to catch those needles.
Okay, and what about if we move to the other side of the knee? If we are repairing the lateral meniscus using an inside-out technique, What is the major anatomical casualty we are terrified of hitting?
Laterally, the anatomical structure at greatest risk is the common peroneal nerve.
The common peroneal.
It wraps right around the bony neck of the fibula, sitting dangerously, uncomfortably close to the posterolateral joint capsule where your needles are exiting.
That sounds incredibly risky.
It is. This anatomical reality dictates our entire surgical technique. It is exactly why lateral meniscal repairs are meticulously, non-negotiably performed with the knee flexed to 90 degrees.
How does flexing the knee to 90 degrees actually protect the nerve?
By flexing the knee, you put profound slack on the common peroneal nerve and its surrounding soft tissues, allowing the nerve to physically fall further posteriorly, dropping safely backward and away from the trajectory of your advancing needles.
Oh, I see.
If you leave the leg straight, the nerve is pulled taut right across your firing line.
Okay, let me pause and clarify the stakes here for you listening, because not all nerve injuries are created equal. The saphenous nerve on the medial side is a purely sensory nerve, but the common peroneal nerve on the lateral side provides the crucial motor innervation to the anterior compartment of the lower leg.
Exactly right.
So, medial risks a sensory nerve resulting in a numb patch on the patient's skin, but lateral risks a motor nerve, which results in a devastating, life-altering foot drop where they cannot lift their foot to walk.
Medial sensory lateral motor, which tells you immediately which nerve injury carries the most catastrophic surgical morbidity, even though the medial sensory nerve injury is statistically the far more common complication.
Right. You can apologize for a numb patch. You will be sued for a foot drop.
Well said.
And to tie a perfect bow on this surgical section, let's formally state the healing rate question we unpacked during our cold open, just to ensure the numbers are locked in.
Let's state it formally for the record. Repair of a meniscal tear performed in conjunction with an anterior cruciate ligament reconstruction leads to a significantly higher rate of healing.
Which is?
Specifically, 92% when combined with an ACL versus 67% for an isolated repair.
92% with, 67% without. And the biological mechanism is exactly that beautiful accidental synergy we talked about.
The bone tunnels.
Yes, the aggressive drilling of bone tunnels acts as a massive marrow-stimulating technique. It floods the joint with pluripotent stem cells, which are basically biological blank slates, cellular contractors waiting for architectural blueprints to start building.
I love that analogy.
It combines with the post-operative haemarthrosis to provide the biological scaffolding that the avascular white and red-white zones desperately lack. It's all about importing blood supply.
Now here comes the trap. Before we move into clinical patterns, we have to highlight a beautifully deceptive trap hidden in that all-inside question from earlier.
Oh, right, the distractor options.
One of the distractor options for the main advantage of an all-inside repair was better visualization of the posterior horn.
Which honestly sounds incredibly plausible again, because if you watch these surgeries, all inside devices are almost exclusively used for tears located way in the back, in the posterior horn of the meniscus. So you assume it gives you better vision back there.
They are used posteriorly, yes, but they are used there precisely because the posterior horn is incredibly difficult to physically reach with an inside-out needle without making a massive, dangerous incision in the back of the knee.
Ah, so it's about reach, not sight.
The surgical advantage is entirely about physical access, not optical visualization. Think about it. You are looking through the exact same arthroscope, utilizing the exact same 30-degree camera angle, displaying on the exact same high-definition monitor, regardless of which repair technique you choose.
Right, the camera doesn't change.
You see the tear exactly the same either way. You have to read the noun carefully. The trap is confusing physical access with optical visualization. Do not fall for it.
Let's get the one-liner for this section.
Let's summarize the mechanics and the anatomy to close this out. All inside repair is faster and avoids a risky accessory incision. The inside-out vertical mattress remains the undisputed biomechanical gold standard for strength. The saphenous nerve is the primary medial casualty, while the common peroneal is the lateral danger. And performing a repair concurrently with an ACL reconstruction takes your meniscal healing rates from a mediocre 67%, all the way to a robust 92%.
Awesome. Okay, we've spent a lot of time inside the operating room. I want to transition now to the clinic. We're taking the biomechanics we just discussed and applying them to pure clinical pattern recognition based on patient history and imaging.
Exactly. I'm going to give you two classic patient presentations. both of which have been heavily rewritten from the bare-bones source material so that you can diagnose them purely by ear, utilizing applied biomechanics.
Okay, hit me with a clinical scenario. I've been reviewing MRI signs all week. I think I'm ready to spot the traps.
A young man is playing football. He plants his foot into the turf, twists his knee violently to change direction, and feels a deep, agonizing pop.
Ouch.
He presents to your clinic the next morning in a wheelchair with a knee that is firmly mechanically locked at about 20 degrees short of full extension.
20 degrees, 20 degrees short, right?
No matter how hard he tries or how much pain medication you give him, he physically cannot straighten his leg. You get an MRI, and when the radiologist reads the sagittal slice right through the center of the intercondylar notch, the MRI shows a second thick band of low-signal tissue lying immediately anterior and perfectly parallel to the posterior cruciate ligament.
So, if I'm looking at the report, it is describing an image that appears to show two PCLs right next to each other where there should only be one.
That is the famous double PCL sign. What is the diagnosis?
Well, if I see a thick band in the notch, I might initially think he tore his ACL and it scarred down, but the locked knee is the dead giveaway. That is a displaced bucket handle tear of the medial meniscus.
It is a massive bucket handle tear of the medial meniscus with the central fragment entirely displaced into the intercondylar notch.
Let's explain why it looks like that.
The tear runs longitudinally through the substance of the meniscus, creating a long, continuous handle of free tissue. That handle flips over centrally, like the handle of a bucket dropping down, and it comes to lie directly in the notch, perfectly parallel to and just slightly anterior to the native PCL.
And on an MRI slice, it mimics a second cruciate ligament flawlessly.
Precisely.
And it is almost always the medial meniscus specifically, right? The lateral side doesn't really do that.
Correct. Bucket handle tears are far, far more common medially. To understand why, you have to picture the peripheral anatomy of the tibia.
Okay, picturing it.
The posterior horn of the medial meniscus is incredibly firmly tethered to the tibial plateau by the thick meniscotibial ligaments that is heavily anchored down.
So it can't move much.
Because it is so immobile and trapped, when the femur forcefully twists on top of it, the shear forces generated are enormous. The tissue cannot yield, so a massive longitudinal tear propagates, leaving a long, free handle of meniscal tissue that simply flips into the empty center of the joint.
Which explains exactly why the clinical presentation is a hard, locked knee.
Exactly. It presents as a hard mechanical block to extension. That thick, rubbery handle of meniscal cartilage is sitting right in the middle of the intercondylar notch, occupying the exact physical space where the femoral condyle needs to glide during terminal extension.
Like a wedge.
It acts exactly like a thick rubber doorstop wedged violently into a door hinge. You can push all you want, but the door will not close.
And because it is a true, irreducible mechanical block, this constitutes one of the very few genuinely urgent surgical problems in the realm of meniscal pathology.
That's right.
You cannot send this patient to 6 weeks of physical therapy and tell them to stretch it out. You have to go into the OR and move the doorstop.
Let's move to the second clinical pattern. I want to see how the fluid dynamics change when the tear isn't locking the joint, but just irritating it.
Bring it on.
Pattern number 2. A 45-year-old woman presents to your clinic. She points to the back of her knee and complains of a soft, fluctuant, balloon-like swelling right in the posteromedial popliteal fossa.
Okay, back of the knee.
She notes that the mass becomes much more prominent and tight when she fully extends her knee, and it becomes softer, almost completely disappearing when she flexes it. What is she most likely to have brewing inside her joint?
Okay, that physical description, swelling in the back of the knee that changes tension with flexion, is the classic textbook presentation of a popliteal cyst, commonly known as a Baker's cyst.
Yes.
But the key detail you gave me here is her age. In a 45-year-old adult, a Baker's cyst is almost never a primary diagnosis. In an adult, it means there is an underlying intra-articular pathology generating massive amounts of excess fluid, and the cyst is just the overflow valve.
Excellent clinical reasoning. Which specific intra-articular pathology are we statistically talking about?
Statistically, a medial meniscal tear.
It points to a medial meniscal tear in 70% of adult cases.
70%.
And there is a second, even larger statistical correlation you must know to pass this module. This presentation points to an underlying articular cartilage lesion in 85% of cases.
Let's do a say it back for this one. Let me cement those statistics for you because they fundamentally change how you will treat this patient in practice. A popliteal cyst in an adult means that 70% of the time, they have an underlying medial meniscal tear.
Correct.
And 85% of the time, they have an articular cartilage lesion. The fundamental takeaway is that the cyst itself is merely a symptom of the joint screaming for help. It is not a primary disease of the popliteal fossa.
70% medial meniscus, 85% cartilage lesion.
What about the lateral meniscus?
By comparison, lateral meniscal tears only occur in about 20% of these cases. And the practical surgical consequence of this fluid dynamic is the most important part of the entire module. Obviously, you just go in and cut out the cyst, right? The patient complains of a lump, so you surgically remove the lump. Simple mechanical problem, simple mechanical fix.
No, that is the trap I almost fell for as a junior trainee. You do not simply cut out the cyst. The cyst is just a pressure relief valve for a swollen, angry knee.
Exactly.
If you surgically excise the cyst from the back of the leg, but you leave the torn, grinding meniscus or the degrading, shedding cartilage inside the front of the knee, the joint will just produce more inflammatory fluid. The pressure will build, and the cyst will recur almost immediately. You must treat what is inside the joint.
You treat the engine, not the exhaust pipe.
And it is worth briefly contrasting this presentation with pediatric patients, just so you don't get them confused.
Very briefly, yes. In a child, a popliteal cyst is an entirely different beast biologically. It is usually a primary benign condition. There is no meniscal tear. There is no arthritis. It almost always resolves entirely without treatment as the child grows. It is only in adults that the cyst acts as a flashing red light signaling profound internal derangement.
All right, time for the one-liner.
Synthesizing this clinical segment. The double PCL sign on an MRI dictates a displaced bucket handle medial meniscal tear presenting with a hard, mechanically locked knee, and an adult presenting with a popliteal cyst means a medial meniscal tear 70% of the time, and a cartilage lesion 85% of the time.
All right, let's do a rapid-fire recap. 1, a consolidation of the first 3 segments before we dive even deeper into the avascular tissues of the joint.
Go for it.
We started with zones. The red zone is the peripheral third, highly vascularized from the parameniscal capillary plexus. The red-white zone is the middle. The white zone is central, entirely avascular, and relies on the cyclic loading of a mechanical sponge effect for nutrition.
Spot on. That classification belongs to Arnoczky and Warren. Arnoczky and Warren, published in 1982.
Never forget that eponym.
For tears, longitudinal tears repair best because they run safely with the circumferential. Type 1 collagen fibers, preserving hoop stress. Radial tears cut across those fibers and destroy the hoop stress. And tears within 3 millimeters of the menisco-synovial junction have the most reliable healing potential.
Perfect anatomical summary.
Regarding repair, all inside techniques are quicker and spare the patient an incision, while the inside-out vertical mattress remains the biomechanical gold standard, though long-term outcomes are equivalent.
Yep.
If you are operating medially, protect the infrapatellar branch of the saphenous nerves. Laterally, protect the motor function of the common peroneal nerve by flexing the knee to 90 degrees. 90 degrees.
90 degrees is critical there.
And remember the magic biological synergy. Isolated repair heals at 67%, but paired with an ACL reconstruction, healing jumps to 92%.
Excellent.
And finally, clinical patterns. A double PCL sign means a displaced bucket handle medial tear with a mechanically locked knee. An adult popliteal cyst means a 70% chance of a medial meniscal tear and an 85% chance of a cartilage lesion with only 20% laterally. Always treat the joint, never just the cyst.
Fantastic recap. Now, if the meniscus struggles with limited blood supply, we are moving into a tissue that essentially has none at all.
Right, the cartilage.
Hyaline articular cartilage, the pristine, frictionless white coating on the ends of your bones, is profoundly avascular. We are going to tackle 3 specific cartilage questions, and when viewed together, they provide a bracingly honest, sometimes depressing account of a surgical field that frequently promises far more than it can biologically deliver.
Let's start with one of the most common cartilage procedures performed on the planet, microfracture.
Imagine a 26-year-old athlete who sustains an isolated full-thickness chondral defect on their femoral condyle.
meaning a chunk of cartilage is missing down to the bare bone, which is treated surgically by microfracture.
Okay, so they have a bare crater.
Exactly. According to the rigorous long-term data, what proportion of these patients will actually report sustained clinical improvement at the 3 to 5 year mark?
The options provided in the multiple choice text span all over the place, from 25% all the way up to 100%.
And what does the data actually say?
75%, 75%.
Approximately 75%, 75%.
Yeah.
That figure comes directly from the pioneering, exhaustive work of Richard Steadman. 75% of patients show improvement at 3 to 5 years, 35 years.
Walk us through the actual technique of microfracture because it relies on the exact same biological hack we discussed in the cold open with the ACL tunnels. It is all about desperation for blood.
It utilizes the exact same principles. In microfracture, the surgeon takes a sharp, pointed metal awl and a mallet and physically punches tiny holes through the hard, calcified subchondral bone plate at the base of the cartilage crater.
Just hammering holes in the bone.
Yes. By punching these holes deep into the bone marrow cavity beneath the joint, you allow marrow elements, fat droplets, red blood cells, and highly potent mesenchymal stem cells to bleed out and fill the defect.
And those mesenchymal stem cells are the key, right? They are the biological contractors I mentioned earlier.
Exactly. These stem cells bleed into the crater and form a superclot, which eventually organizes and hardens into a repair tissue over the ensuing weeks. It is a desperate, traumatic attempt to import a blood supply to a desolate, avascular area.
And who are the ideal candidates? Because clearly 25% of people are still failing. Who actually hits that 75% success rate?
The clinical criteria for success are incredibly strict, and examiners will press you on this. The patients who do best are strictly younger patients with a lower body mass index, so they aren't overloading the fragile clot, and those with relatively small, completely well-contained lesions, meaning the crater has healthy, sheer walls of cartilage around it to protect the clot while it heals.
So they need that structural border.
Yes.
Yeah.
Every single part of that sentence matters deeply when you are sitting in a clinic consenting a patient. If they are older, heavy, or have massive uncontained sliding defects, microfracture will likely fail quickly and miserably.
Now let's look at an older, even more aggressive cartilage technique that you don't see as much anymore. Abrasion arthroplasty.
This question is phrased in the negative, which makes it an excellent critical thinking exercise for a candidate. The source asks, which statement regarding abrasion arthroplasty has not been reported in the clinical literature?
The options to choose from include fibrocartilage formation, intermediate or long-term symptomatic improvement in the majority of patients, type 1 collagen predominance, no correlation between radiographic and clinical improvement, and increased radiographic joint space in about half of the patients.
And which of those statements is the clinical myth? What did we lie to ourselves about?
Well, logically, if we are aggressively scraping the joint down to bleeding bone, surely the majority of patients get better, right? So the false statement must be one of the dense collagen ones.
That is the trap. The clinical myth is that the patients actually get better. The false statement is intermediate or long-term symptomatic improvement in the majority of patients.
Wait, really? They don't improve?
That has not been reported. That is the bitter, honest truth of the procedure, and it is the entire point of the question. Abrasion arthroplasty involves taking a fast motorized burr and aggressively scraping away the hardened, eburnated bone of an arthritic joint over a massive surface area to stimulate widespread bleeding. But it rarely provides lasting relief for the majority.
Wait, if the long-term clinical results are so poor, what kind of tissue is that massive area of bleeding bone actually producing? Why did we think it was working?
It produces fibrocartilage, which is predominantly made up of type 1 collagen. And this leads to a massive, frequently tested clinical disconnect.
What's the disconnect?
Following an abrasion arthroplasty, approximately 50% of patients will actually show an increased radiographic joint space on a follow-up X-ray. It looks perfectly like you grew them a brand new, thick layer of cartilage.
That sounds fantastic.
But there is absolutely zero correlation between that beautiful radiographic improvement and actual clinical improvement for the living patient.
Let me highlight that for you listening, because it is a staggering reality check. The X-ray gets better, but the patient doesn't.
The X-ray gets remarkably better, and the patient absolutely doesn't. That is a sentence worth remembering well beyond this specific multiple-choice question because it haunts the entire field of orthopedics.
I need to understand the cellular biology here. Why is type 1 collagen such a profound problem? If it fills the anatomical hole and widens the joint space on an X-ray, why doesn't it relieve the patient's grinding pain?
Because of the molecular architecture. Normal, pristine, hyaline articular cartilage, the miraculous Teflon-like coating you are born with, is made of type 2 collagen.
Type 2, okay.
Type 2 collagen interacts with giant proteoglycan molecules to trap massive, dense amounts of water, giving it incredible shock-absorbing and virtually frictionless properties.
And fibrocartilage?
Fibrocartilage, on the other hand, is made of type 1 collagen. Type 1 is ropey, stiff, dense, and inflexible. It is essentially just hard scar tissue.
So it's just filling the gap with scar.
Exactly. It blindly fills the anatomical crater, which is what makes the joint space look wider and healthier on a simple X-ray. But it doesn't possess a single one of the mechanical shock-absorbing properties of the tissue it replaced. Under the heavy, cyclic loading of daily walking, that stiff scar tissue quickly breaks down, fragments, and the agonizing pain returns.
Type 2 is what you want. Type 1 is what you get.
Type 2 is what you want. Type 1 is what you get. That is the tragedy of cartilage regeneration in a 12-word summary. You want pristine hyaline, your body gives you cheap scar tissue.
Let's finish this cartilage section with a condition that terrifies parents. It affects kids and young adults. Osteochondritis, dissecans, or OCD.
This is a fascinating condition where a localized portion of subchondral bone mysteriously loses its blood supply, dies, and threatens to break off into the joint, taking the overlying pristine cartilage with it like a sinkhole collapsing.
Like a pothole forming in the knee.
The source asks a very specific epidemiological question. What percentage of osteochondral lesions of the distal femur are found to be bilateral?
The answer is 20 to 30%? 20 to 30%.
20 to 30% of distal femoral OCD lesions are bilateral. And this statistic is rigorously, repeatedly tested because of what it demands of you as a clinician sitting in the exam room.
Which is?
What is the immediate, non-negotiable clinical implication when you look at an X-ray and see a unilateral OCD lesion in a 15-year-old's knee?
You absolutely must image the other knee, even if it doesn't hurt.
Image the other knee. Every single time. Any young patient presenting with a distal femoral osteochondral lesion must have the contralateral side radiographically assessed because up to a third of them will have an identical insidious lesion developing on the other side.
And it might not even have symptoms yet.
Crucially, that second lesion is often completely asymptomatic at the time of presentation. Finding it early is critical because it is infinitely easier to treat a stable, intact lesion before it completely dissects and falls into the joint as a massive, destructive, loose body.
Time for the one-liner for cartilage.
Synthesizing the cartilage dilemma. Microfracture yields approximately 75% improvement at 3 to 5 years. 3 to 5 years by creating a superclot. Abrasion arthroplasty produces dense, type 1 fibrocartilage where the radiographs improve while the patients tragically do not. And distal femoral osteochondral lesions are bilateral in 20 to 30% of cases, meaning you must always aggressively scan the other knee.
So we've spent the last 20 minutes talking about tissues that are starving for blood. We are transitioning now from cartilage, a tissue that has practically no blood supply, to the synovium, the thin lining of the joint capsule, which is incredibly richly vascularized.
The opposite end of the spectrum.
Right. And we're going to look at what happens when a tissue with that much blood supply aggressively turns against the joint.
We have 3 specific synovial and juxta-articular conditions to unpack here. They can all present somewhat similarly clinically, a swollen, aching joint, but they were distinguished entirely by what they systematically leave behind on a radiograph. Let's start with the first presentation.
I am ready. Give me the triad of findings.
A patient presents with chronic, unexplained joint pain and swelling that hasn't responded to anti-inflammatories. You order a set of plain to radiographs.
Okay.
The films reveal multiple, well-defined cystic erosions located distinctly on both sides of the joint line. However, despite these aggressive-looking, punched-out bony cysts, the actual joint space is perfectly preserved, and there's absolutely no generalized osteopenia, meaning the surrounding bone density is completely normal and healthy. What is the diagnosis?
That specific triad of findings, cysts on both sides, preserved space, no osteopenia points definitively to pigmented villonodular synovitis, or PVNS.
PVNS, exactly. And the absolute key radiographic discriminator you must recognize when the examiner hands you the film is that phrase, cystic erosions on both sides of the joint.
Why does it happen symmetrically on both sides?
Because PVNS is characterized by a massive, highly vascular, aggressive proliferation of the synovial lining. This hypertrophic, overgrown synovium fills every millimeter of the joint space, drastically increasing the pressure, and it presses physically outwards in every single direction simultaneously.
Like it's trying to burst out.
Wherever that aggressive, pulsing mass of tissue touches bone on the femoral side or the tibial side, it slowly, relentlessly pits and erodes into it.
And while PVNS can theoretically affect any joint with a synovial lining, which specific anatomical joint suffers the absolute worst structural consequences from this disease process?
The hip joint.
Why the hip? It's the exact same disease process, isn't it? The same cells.
It is the exact same histopathology, but the structural consequences are exponentially worse in the hip, purely because of the physical nature of the container. The knee joint has a massive, capacious, highly distensible capsule. The swelling can expand endlessly upwards into the suprapatellar pouch. The knee can look like a balloon, but the pressure stays relatively low. The hip joint, conversely, has an incredibly thick, tight, unforgiving fibrous capsule designed for maximum stability. When the synovium hypertrophies inside the hip, it has literally nowhere to expand. The intracapsular pressure rises exponentially faster, which means those outward erosive forces on the femoral head and the acetabulum are drastically more severe. The same disease yields exponentially worse consequences purely because of the physics of the container.
Let's move to the second synovial condition. I know this one is a favorite for oral boards.
This next one is asked twice in the source material in different formats, which is a massive neon sign that it matters deeply.
They really want you to know it.
They do. A patient presents with a swollen, mechanically clicking, catching joint. Imaging reveals that the joint capsule contains dozens, sometimes hundreds, of multiple loose bodies that have a distinct cartilaginous appearance on MRI.
Just floating around.
Yes, you determine they are formed by an active biological process of synovial metaplasia. What is the definitive surgical treatment?
Well, the disease is obviously synovial chondromatosis. And logically, if a patient has 200 loose pearls of cartilage grinding up their joint, the treatment is to go in arthroscopically and meticulously remove every single one of those loose bodies so the joint stops grinding. Simple mechanical problem, simple mechanical fix, right?
And if you say that confidently to the examiner, you will get exactly half marks and you will fail the station. The full, absolutely correct answer is arthroscopic removal of the loose bodies plus a comprehensive aggressive synovectomy.
Why is the synovectomy absolutely mandatory? Why expose the patient to a much longer, bloodier surgery to remove the lining when I already took out the rocks that were causing the pain?
Because you have to understand what the word metaplasia actually means in this disease. Metaplasia is a cellular identity crisis.
An identity crisis.
The synovium is the factory. In synovial chondromatosis, the cells of the delicate synovial membrane undergo a pathological identity crisis. They literally transform their biology into chondrocytes, and they begin actively producing nodules of hard cartilage right there in the lining.
So they're making the loose bodies?
These nodules eventually break off and float around the joint as loose bodies. If you just meticulously fish out all 200 loose bodies, but you leave the diseased metaplastic synovial lining behind, the factory is still completely open for business. It will simply manufacture 200 more loose bodies over the next 12 months, and the patient will be back in your operating room.
Okay, that makes perfect biological sense. The loose bodies are merely the mechanical symptom of the disease. The diseased synovium itself is the actual root cause.
Exactly. And that fundamental surgical principle, that you must aggressively remove the vascular tissue that is actively generating the problem, not just lazily clean up the debris it leaves behind, is the exact same reason you have to perform a massive radical synovectomy when treating the PVNS we just discussed as well. You have to remove the factory.
And the third condition, you said it was juxtaarticular.
The third condition isn't strictly synovial, but it lives in this same family of complex radiographic, what on earth is this? Questions. An otherwise completely healthy patient gets an X-ray for a minor ankle sprain.
Just a normal sprain.
The radiograph reveals multiple small, incredibly well-defined sclerotic, foci-dense white spots clustered thickly around the joints. These spots are perfectly symmetrical when you X-ray the other side, and the limb is entirely asymptomatic.
That is osteopoikilosis.
Osteopoikilosis, literally translated from Greek as mottled bone. And it belongs to a very specific, highly tested category of radiographic findings. It is a strict do not touch lesion, meaning it is a completely benign, inherited, incidental anatomical anomaly. It requires absolutely no biopsy, no serial follow-up scans, and zero surgical intervention.
So just leave it alone entirely.
The true danger of osteopoikilosis is not the disease process itself, because there isn't one. The danger is the junior, overeager, panicked surgeon who looks at the X-ray, assumes the worst, and decides to biopsy it, thereby introducing the immense risks of general anesthesia, deep bone infection, and surgical morbidity into a perfectly healthy limb.
Which brings us directly to a trap that is absolutely worth naming, because it is the exact reason those junior surgeons panic when they see this film. When a radiologist dictates a report that reads multiple sclerotic bone lesions, the immediate terrifying thought that jumps into everybody's mind is osteoblastic metastases, most commonly from aggressive prostate or breast cancer.
Let's break down osteoblastic for the listener, because normally we think of cancer eating away at the bone, making it weak.
Right, those are lytic lesions. They destroy bone. But osteoblastic metastases, osteo meaning bone, blastic meaning building, are cancers that aggressively, chaotically build disorganized, dense bone. On an X-ray, they look like bright white sclerotic spots, exactly like osteopoikilosis.
Exactly. So if I'm looking at a film with multiple dense white spots on the bone and the stakes are literally life or death, how do I reliably tell them apart? How do I distinguish perfectly benign osteopoikilosis from aggressive metastatic terminal cancer?
The crucial clinical discriminators are distribution and symmetry. Osteopoikilosis is highly perfectly symmetrical. If it is in the right knee, it is in the left knee.
That makes it easy to spot if you look for it.
It is tightly clustered around the joints, specifically in the epiphyses and metaphyses, and crucially, the patient is completely asymptomatic with entirely normal blood panels.
And the metastases.
Metastatic lesions, however, are almost always chaotic and asymmetrical. They heavily favor the axial skeleton, the spine, the pelvis, the ribs, rather than the appendicular joints. And tragically, the patient is usually systemically unwell, complaining of deep, relentless bone pain, or they already have a known primary malignancy. Symmetry and location are your absolute guides.
Okay, let's lock in the one-liner for this section. To summarize this radiographic gauntlet, PVNS aggressively erodes both sides of the joint simultaneously and is structurally worst in the tight, high-pressure capsule of the hip. Synovial chondromatosis requires you to surgically take out the factory lining via a full synovectomy in addition to removing the loose bodies. And osteopoikilosis is the ultimate symmetrical do-not-touch lesion that only ever becomes dangerous when a surgeon decides to blindly biopsy it.
We are down to our final segment of pathologies, both of which present clinically as an acutely, painfully swollen knee, but for entirely different, catastrophic reasons. We are dealing with fluids that absolutely should not be in the joint space. One is filled with blood and the other is filled with pus. Let's tackle the blood first.
A young boy presents to the emergency department with a history of recurrent, spontaneous hemarthrosis of the knee, meaning, as we defined earlier, his knee repeatedly fills to the brim with whole blood without any major trauma.
So, no injury at all.
He didn't fall, he didn't twist it, it just filled up. What is the most likely overarching diagnosis?
That presentation of spontaneous bleeding into a joint in a young male is classic for haemophilic arthropathy. Haemophilic arthropathy, correct. Now, I have to stop here and explicitly, forcefully correct the source material because the text makes a fundamental, highly dangerous genetics error in its explanation. And if you repeat it to an examiner, you will fail your basic science boards instantly.
Okay, I read the source carefully. What did it get wrong?
In the explanatory text, the source correctly identifies that the underlying causes of this arthropathy are usually hemophilia and von Willebrand disease, but it then explicitly states they are X-linked, affecting boys only. That broad genetic statement is completely wrong for one of those specific conditions. Wait, which one is wrong? Because I definitely learned that hemophilia is the classic X-linked disease.
Let's separate them carefully. Hemophilia A, which is a severe factor VIII deficiency, and hemophilia B, which is a factor IX deficiency, are indeed X-linked recessive disorders.
Okay, so that part's true.
Because they are X-linked recessive, they do predominantly affect boys.
Mm-hmm.
However, von Willebrand disease is an autosomal disorder. It is most commonly autosomal dominant, meaning it affects males and females completely equally. And critically, von Willebrand disease is in fact the most common inherited bleeding disorder in the entire general population.
Let me say it back here. Let me repeat those corrected genetics so you listening have them permanently locked in, because I know how heavily basic genetics are tested in these modules.
Go ahead.
Hemophilia A and B are strictly X-linked recessive, meaning they primarily affect boys. Von Willebrand disease is autosomal, meaning it affects both sexes equally, and it is the most common inherited bleeding disorder overall.
Hemophilia is X-linked. Von Willebrand is autosomal. If you take away only one single correction from this entire module, make sure it is that one. It spans orthopedic pathology and fundamental hematology.
And what about the destructive joint disease itself? We know blood doesn't belong there, but how does bleeding into a joint actually ruin the pristine hyaline cartilage?
Recurrent bleeding into the enclosed, pressurized joint space causes massive synovial hypertrophy. The lining gets thick and angry.
Okay.
But more importantly, as those trapped red blood cells break down and degrade, they deposit massive amounts of iron in the form of hemosiderin into the synovial tissue. This hemosiderin is incredibly toxic to the joint environment.
It poisons the joint.
It drives a vicious inflammatory cascade and activates enzymes that lead to the rapid, progressive, irreversible destruction of the hyaline cartilage. The knee, the ankle, and the elbow are the classic, highly vulnerable target joints for this devastating arthropathy.
Let's move from blood to pus, the final major pathology question.
Which statement regarding septic arthritis is correct? The correct answer provided in the source is, treatment involves urgent joint irrigation. But in this case, the distractor statements, the false ones, are actually worth far more educational weight than the true one, because they represent incredibly common, dangerous clinical misconceptions that junior doctors make every day. Let's take them individually.
What's the first false statement we need to debunk?
The source implies a different organism, but you must know that Staphylococcus aureus is the absolute commonest causative organism for septic arthritis across all demographics.
So Staph aureus.
It is not Streptococcus, and it is certainly not Haemophilus influenza, which has plummeted to near zero since the advent of routine childhood vaccinations. Second, septic arthritis predominantly affects the large, weight-bearing joints, the knee, the hip, and the shoulder. It does not predominantly target small joints like the fingers or toes.
And what is the hard rule regarding antibiotics? Because this is where people make massive limb-threatening errors in the emergency department.
This is the critical, inviolable rule. Antibiotics should absolutely not be withheld. Pending final microbiological culture results in a patient who is systemically unwell or toxic.
Which I think is a paradigm some clinicians are still taught in old school medical school lectures, to always wait for the final culture so you can perfectly target the drug rather than guessing with broad spectrum antibiotics and creating resistance.
The clinical nuance is worth stating properly so you don't misunderstand the workflow. You should absolutely attempt to aspirate the joint with a needle before you push the first dose of intravenous antibiotics wherever it is practically possible, because early aspiration vastly improves your culture yield.
You want to know exactly what bacterial bug you are fighting.
But in a septic, systemically compromised patient who is spiking a fever, you do not delay life-saving and joint-saving empirical treatment while waiting 2 days for the lab to plate the fluid. You sample fast, and then you treat immediately.
And the surgical treatment itself is irrigation.
Copious, high-volume irrigation and aggressive mechanical debridement, either done open or arthroscopically, plus targeted intravenous antibiotics. And the source makes a very valid point that arthroscopic irrigation is highly effective and significantly reduces the massive morbidity and pain associated with a large open arthrotomy incision.
We have one final biomechanical question left in this segment, moving away from acute infection and into early osteoarthritis.
Yes. What is the most appropriate surgical management for isolated medial compartment knee osteoarthritis in a young, highly active patient who presents with a varus or bow-legged deformity?
Well, they are too young for a total knee replacement, so the answer would be a high tibial osteotomy, or HTO.
A high tibial osteotomy, exactly. Instead of replacing the joint with metal and plastic, you perform a profound structural realignment.
You actually cut the bone, right?
You strategically cut the proximal tibia with a saw and wedge it open to unload the damaged medial compartment, physically shifting the heavy mechanical weight-bearing axis of the leg laterally over to the healthy, pristine cartilage on the outside of the knee. It buys the patient critical time.
But there are exceptions.
But to pass the exam, you must intimately know the strict contraindications for an HTO, because that is exactly how it will be tested. They will give you a patient and ask why you can't do it.
Okay, what are the 4 hard contraindications where an HTO will fail?
You cannot perform an HTO if the patient has widespread inflammatory arthritis, like rheumatoid.
You cannot do it if they have a severe flexion contracture that is greater than 15 degrees, 15 degrees.
Greater than 15 degrees, 15 degrees.
You cannot do it if they have bicompartmental osteoarthritis, meaning both sides of the joint are already worn out. And you cannot do it if they have gross ligamentous instability.
Inflammatory arthritis, a flexion contracture over 15 degrees, bicompartmental disease, and ligamentous instability.
Those are the 4 hard stops. And if you notice the underlying theme of those contraindications, the osteotomy operation only works mathematically if there is a completely healthy, untouched lateral compartment to move the heavy mechanical load onto, and a perfectly stable, tight ligamentous envelope to hold it there securely.
Otherwise, it falls apart.
If the whole joint is inflamed, or if it is inherently wobbly and unstable, shifting the weight will just accelerate the total destruction of the knee.
Time for our scar story. Before we wrap up with the massive recap and the lightning round, I want to ask about the reality of these conditions. We've talked about a lot of pathologies today, meniscal tears, cartilage defects, PVNS, but is there one specific scenario hidden in this module that goes catastrophically badly in real life? A mistake that haunts people?
There is. And it is the one that truly haunts orthopedic surgeons on call. It is the tragedy of the missed septic knee.
How does that happen?
It typically unfolds exactly like this. A middle-aged patient presents to the emergency department at 2 in the morning. They have a massively swollen, exquisitely painful, bright red knee and a mild low-grade fever.
Okay.
The junior doctor looks at the chart, takes a brief history, and sees a previous medical history of gout. They appropriately aspirate the knee, send the cloudy fluid to the lab, and the lab calls back an hour later to say, "We found uric acid crystals in the fluid."
So somebody confidently labels it an acute flare of gout, prescribes anti-inflammatories, and goes to sleep.
But based on what we just discussed, finding crystals doesn't actually exclude a coexisting bacterial infection, does it?
No, it absolutely doesn't. Crystals do not exclude infection, and crucially, the two conditions coexist far more often than anyone ever expects.
Really? Together? An infected joint is an acidic, highly inflamed environment, which can actually cause uric acid to precipitate and trigger a gout attack simultaneously. So, relying blindly on the gout diagnosis, the team decides to hold off on empirical antibiotics. They write in the medical notes, "We will wait for the final culture results to be certain." And the patient simply sits there in a hospital ward bed for 36 hours. 36 hours.
Oh, wow. And what is actually happening physically inside that joint during those 36 hours of waiting?
During those 36 hours, the precious, irreplaceable hyaline cartilage is trapped in a closed, highly pressurized bath of highly destructive bacterial metalloproteinases, which are essentially tiny metal-dependent molecular scissors that indiscriminately chop up the collagen and violent leukocyte enzymes from the immune system.
It's dissolving.
The pristine white cartilage is literally being digested alive.
Yeah.
When the culture finally comes back positive for Staph aureus 2 days later, you panic and rush them to the operating room. You can meticulously wash out all the pus, but you absolutely cannot wash out the enzymatic structural damage that has already been done to the deep cartilage matrix.
The damage is permanent.
And that joint is destroyed. That patient's knee is now on an irreversible, agonizing path to requiring a total knee replacement 15 years earlier than they otherwise would have.
And all of that massive lifelong morbidity stems from a simple sequencing decision made at 2 in the morning by someone trying to be careful with antibiotics.
All because someone treated the phrase, "wait for the culture," as an inviolable, hard academic rule, rather than a preference that must be immediately abandoned when a patient's joint is acutely clinically at risk.
That is sobering. Let's get the one-liner for this section.
Let's summarize the blood, the pus, and the bone. Hemophilia is an X-linked recessive disorder, while von Willebrand disease is strictly autosomal. Septic arthritis is most commonly caused by Staph aureus in a large weight-bearing joint, and you must aspirate and then treat immediately without delaying for cultures. And isolated medial compartment arthritis in a young varus knee is treated with a high tibial osteotomy, provided the rest of the joint is pristine.
All right, let's lock in the back half of this deep dive with recap to a rapid-fire summary.
Ready?
We covered cartilage. Microfracture works by awling the subchondral bone to release marrow and stem cells and yields about 75% improvement at 3 to 5 years. 3 to 5 years. Best in young, thin patients with small lesions.
Right.
Abrasion arthroplasty fails because it produces stiff, ropey, type 1 fibrocartilage. The radiographs might show increased space, but the patient's symptoms do not improve. For distal femoral OCD lesions, remember they are bilateral 20 to 30% of the time, so you must always image the other knee.
Great.
Next, the synovium. PVNS is an aggressive proliferative disease that causes well-defined cystic erosions on both sides of the joint simultaneously, and the destruction is mechanically worst in the tight container of the hip.
That's right.
Synovial chondromatosis requires arthroscopic removal of the loose bodies plus a full synovectomy to remove the metaplastic factory. Osteopoikilosis presents as symmetrical, asymptomatic sclerotic foci around the joints. It is a benign, do-not-touch lesion that must not be mistaken for asymmetrical axial metastases.
Perfect distinction.
Finally, blood and pus. Hemophilia A and B are X-linked recessive, while von Willebrand disease is autosomal dominant and affects both sexes equally. Septic arthritis is driven by Staph aureus. Aspirate for a sample, but never ever delay life-saving antibiotics in a sick patient.
Never.
And for a young patient with isolated medial osteoarthritis and a varus bow leg, the answer is a high tibial osteotomy, provided they don't have inflammatory arthritis, a flexion contracture over 15 degrees, bicompartmental disease, or ligamentous instability.
Excellent recap.
We have reached the final crucible. This is the lightning round. I am going to throw the core, heavily tested concepts at you exactly as they appear in the source material, and you are going to give the listener the precise, concise answers they need to pass their exams. Are you ready?
I am ready. Fire away.
Which meniscal zone possesses the absolute best healing potential?
The red zone, which is the peripheral third.
Which meniscal zone is completely avascular?
The white zone, which is the central third.
Whose classification defines these three meniscal zones?
Arnoczky and Warren. Arnoczky and Warren, 1982.
Which specific tear pattern is structurally the most repairable?
A longitudinal tear.
What is the primary clinical advantage of an all-inside meniscal repair?
Ease of use, less operative time, and no accessory incision.
What remains the biomechanical gold standard for meniscal repair strength?
The inside-out vertical mattress technique.
Which specific nerve is at greatest risk during a medial inside-out meniscal repair?
The saphenous nerve, specifically its infrapatellar branch.
Which nerve is at greatest risk during a lateral meniscal repair?
The common peroneal nerve, which is protected by flexing the knee to 90 degrees.
What is the exact healing rate of a meniscal repair performed with and without an ACL reconstruction?
92% with, 67% without.
What does a double PCL sign on an MRI indicate?
A displaced bucket handle tear of the medial meniscus.
In an adult presenting with a popliteal cyst, what is the statistical rate of an underlying medial meniscal tear?
70%.
And the rate of an underlying articular cartilage lesion in that same patient?
85%.
What is the success rate of a microfracture procedure at 3 to 5 years?
About 75%.
What specific type of tissue does an abrasion arthroplasty produce?
Fibrocartilage, which is predominantly type 1 collagen.
What specific clinical outcome has not been shown for abrasion arthroplasty?
Symptomatic improvement in the majority of patients at intermediate or long term.
What is the bilateral rate for osteochondral lesions of the distal femur?
20 to 30%.
What condition presents with cystic erosions on both sides of a joint with preserved joint space?
PVNS.
Which specific anatomical joint fares the worst when afflicted by PVNS?
The hip, because of its tight capsule and higher intracapsular pressure.
What is the definitive surgical treatment for synovial chondromatosis?
Arthroscopic loose body removal plus a comprehensive synovectomy.
What is the diagnosis for multiple symmetrical juxtaarticular sclerotic foci in a completely asymptomatic patient?
Osteopoikilosis. It is a strict do-not-touch lesion.
What is the most likely diagnosis for a young boy presenting with recurrent spontaneous hemarthrosis?
Haemophilic arthropathy.
What is the genetic inheritance pattern of hemophilia A and B?
X-linked recessive.
What is the genetic inheritance pattern of von Willebrand disease?
Autosomal. It affects both sexes equally.
What is the most common causative organism in septic arthritis?
Staphylococcus aureus.
Should empirical antibiotics ever be withheld pending a culture result in a toxic septic patient?
No. Aspirate if you practically can, then treat immediately.
What is the surgical procedure of choice for a young patient with isolated medial compartment arthritis and a varus deformity?
A high tibial osteotomy.
What are the 4 strict contraindications to performing that osteotomy?
Inflammatory arthritis, a flexion contracture over 15 degrees, bicompartmental disease, and ligamentous instability.
Wow. Okay. Pulling all of this dense physiological material together, synthesizing this entire module for you listening, it really just comes down to one single unifying concept. The whole module was a masterclass in blood supply.
The whole module was blood supply. Think about the tissues we just traversed over the last hour. The meniscus only heals in the peripheral zones where it actually has a dedicated vessel.
Right.
The central cartilage doesn't heal at all, so we resort to drilling traumatic holes into the subchondral bone just to aggressively import blood from the marrow, and what we get back is a stiff, inferior scar.
Type 1 collagen.
Exactly. And then you have the synovium, which is the one tissue in the joint with an incredibly generous, robust blood supply, which is exactly why when the synovium undergoes pathology and goes wrong, like in PVNS or synovial chondromatosis, it goes wrong so expansively and so aggressively. It has the immense biological fuel required to completely destroy the joint.
It is a delicate, brutal ecosystem. You either starve or you overproliferate. So where are we taking the listener next?
We are going to move slightly anteriorly. We are moving to the very front of the knee. Our next deep dive will tackle the patellofemoral joint, which I can tell you from painful clinical experience is the single anatomical compartment that reliably ruins more total knee replacements and abruptly ends the careers of more young, promising athletes than anything else we will cover in this entire series.
Okay, give me the hook. Give me something to think about before we start Module 7.
Here is the scenario to chew on while you study. A young woman violently dislocates her patella laterally during a gymnastics routine.
Okay, lateral dislocation.
By the time she reaches the emergency room, it has relocated and gone back into place entirely by itself. But when you finally get her MRI, it shows a massive bone bruise on the lateral femoral condyle and a huge, devastating chunk of chondral damage directly on the medial facet of her patella.
Wait, I'm confused by that geometry. That seems entirely backwards. If her patella dislocated forcefully out to the lateral side, why on earth is all the severe cartilage damage located on the medial side?
Because the catastrophic damage doesn't actually happen when the kneecap goes out.
It happens when it comes smashing back in.
Now you are thinking exactly like a surgeon. See you in Module 7.